Imagine looking at a scan of a patient's heart and seeing a severe structural narrowing in a major coronary artery. While it appears to be a candidate for immediate emergency intervention, blood may actually be flowing through this vessel with zero physiological restriction. For decades, cardiology relied on anatomical assessment to predict cardiovascular risk. If a scan showed a physical blockage, a stenosis, the standard protocol was to go in and mechanically open it with a stent or bypass. Recent empirical data from the ADVANCE Registry disrupts that approach. The ADVANCE Registry is a large-scale clinical study tracking the real-world outcomes of patients assessed with advanced flow modeling software. The study revealed a critical data point. Nearly 30% of anatomically severe stenoses, blockages obstructing more than 70% of the vessel, are functionally insignificant. They do not restrict actual blood flow. Treating patients based entirely on 2D pixels leads to unnecessary surgical interventions, while simultaneously missing ischemic events that hide in less obvious plaques. Ischemia is a condition where blood flow is restricted, reducing oxygen supply to the heart muscle. To move beyond purely structural data, physicians are turning to CT-derived Fractional Flow Reserve, or FFRCT. FFRCT is a diagnostic tool that calculates the physiological flow of blood through the coronary arteries using standard coronary computed tomography angiography data. CCTA is a non-invasive imaging test that uses X-rays to provide detailed pictures of the heart's blood vessels. This computational fluid dynamics model displays color-mapped flow rates in Panel A, proving pressure remains stable despite a narrowing. In Panels B and C, the visual narrowing appears significant, but physiological mapping proves there is no actual drop in blood flow. This integration of artificial intelligence and fluid dynamics is shifting the official treatment guidelines of both the American College of Cardiology and the American Heart Association. Cardiology is moving away from static anatomical snapshots in favor of predictive physiological modeling, which is shifting the established clinical data pipeline. To understand why this shift is happening, we have to look at how we traditionally screen for heart disease using coronary artery calcium scoring, or CACS. CACS is a population-level risk stratification tool that uses a CT scan to measure the amount of calcified plaque in the heart's arteries. The standard metric for CACS is the Agatston score. It calculates plaque density by assigning a weighted value to Hounsfield units, a quantitative scale for describing radiodensity. A baseline density of 130 to 199 HU gets a weight of 1, while highly dense calcium over 400 HU gets a weight of 4. That weight is then multiplied by the total area of the plaque in square millimeters. Statistically, this is a highly effective filter. In the PROMISE cohort study, patients who scored an absolute 0 on their calcium test yielded an annual cardiovascular event rate of less than 1%. A calcium score of 0 can overlook positive remodeling. Panels A and B show severe narrowing despite a 0 score. In panels C and D, the vessel wall expands to accommodate soft, non-calcified plaque, hiding the disease without immediately narrowing the lumen. Because they do not register on a calcium scan, these soft plaques go untreated. They are often the culprits in acute type 2 myocardial infarctions, where a sudden mismatch between oxygen supply and demand damages the heart muscle. Macroscopic calcification indicates the historical timeline of the disease. It does not reflect the immediate mechanical risk of a sudden plaque rupture. To assess that immediate risk, cardiologists need to know the exact pressure of blood flowing past a lesion. Historically, this required threading an invasive pressure wire directly into a patient's coronary artery. Now we simulate that pressure drop non-invasively. Diagnostic algorithms apply Navier-Stokes equations to standard CCTA datasets. These are mathematical equations that describe the motion of fluid substances like blood, calculating the exact pressure gradients from one end of a lesion to the other. This gives clinicians a quantifiable threshold. An FFR score of less than 0.8 is the definitive marker of functionally significant ischemia. However, computational fluid dynamics demand extreme precision. These algorithmic models are highly susceptible to input errors. Variables like high heart rates, atrial fibrillation, or poor contrast dye evolution create visual artifacts in the scan. Even minor anomalies can corrupt the fluid dynamic simulation. Atrial fibrillation is an irregular and often rapid heart rate that can cause poor blood flow. Because of these data requirements, Real-world clinical application currently sees a 13% rejection rate for FFRCT scans. While FFRCT serves as a highly accurate predicted engine, its diagnostic power is entirely limited by the need for pristine, artifact-free data. Fluid dynamics solve for blood flow, but the next step is analyzing the structural integrity of the vessel wall itself. That requires artificial intelligence. This CT scan illustrates the Motoyama criteria for vulnerable plaque. Panels C and E contrast a bright white lumen against a dark, low-attenuation necrotic core. The longitudinal view in panels A and B highlights the remaining criteria: positive vessel remodeling and spotty calcification. These vulnerable characteristics often cluster together. In panels A and B, you see extensive plaque buildup spanning the length of the vessel, creating a high-risk atherosclerotic burden. Quantifying the exact ratio of a necrotic core to stable fibrous plaque previously required invasive procedures like intravascular ultrasound or optical coherence tomography. AI deep learning models can now automatically segment and quantify this exact ratio entirely from a non-invasive scan. AI enables the standard CCTA to function as a molecular-level risk stratifier, capable of predicting acute coronary syndromes before they occur. Delegating clinical diagnosis to an artificial intelligence algorithm introduces severe ethical and professional friction for the medical community. A primary concern is algorithmic data bias. An AI model is strictly bound by the limitations of its training data. Models trained predominantly on Caucasian males in high-income nations will output skewed risk profiles for other demographics. This lack of representative data renders these advanced algorithms potentially unsafe for underrepresented populations and low-income regions that bear the majority of the global cardiovascular disease burden. This compounds the black box liability problem. Deep learning systems generate accurate answers, but the exact reasoning inside the algorithm is often opaque to the user. If an AI model flags a benign arrhythmia as critical or misses a vulnerable plaque, an unresolved legal dilemma emerges. Who holds the medical liability? The developer or the clinician who trusted the output? Without explainable AI and rigorous human-in-the-loop oversight, a powerful diagnostic tool rapidly becomes a massive clinical and legal liability. Despite these frictions, this technology is already moving out of the diagnostic reading room and directly into the sterile field of the modern interventional catheterization lab. Preoperative CCTA data, FFRCT flow maps, and AI plaque analysis are converging into unified platforms, piped directly into surgical monitors. Technologies like intraprocedural 3D stent reconstruction allow surgeons to visualize the exact mechanical expansion of a newly placed stent in real time without injecting additional contrast dye into the patient. Augmented reality platforms project these 3D volumes directly into the clinician's field of view, improving surgical ergonomics and spatial assessment. These interfaces allow a cardiologist to navigate complex intravascular physiology without ever breaking the sterile environment. The effectiveness of these real-time surgical tools relies entirely on the absolute mathematical accuracy of the upstream predictive AI models. A newly established clinical pipeline has formed. Non-invasive CCTA, supercharged by artificial intelligence, is now the definitive gatekeeper to the catheterization lab. Treating patients based solely on 2D anatomical severity is no longer the modern standard. Precision Physiology and computational fluid dynamics represent the new standard of care. Machine learning acts as a high-dimensional translator, detecting physiological signals that are entirely imperceptible to the human eye. Because these algorithms are susceptible to bias, human intuition is required, along with ethical oversight, and understanding software limitations are more critical than ever. The medical professionals who master the fluid dynamics and algorithmic biases of these tools will likely define the standard of care for cardiovascular medicine.